Okay, let's get an AP. Coker. Yeah. Let me know when you're ready. Shot. Perfect. Yeah, you can see the tear on both sides. So it's obvious that there's a tear on both sides of this disc, and the dye is leaking into the neuroforamen around the nerve roots on both sides. We're going to repair both sides. That may be why her right arm symptoms are getting worse. Or sorry, her left arm symptoms are getting worse, because we knew she had right arm symptoms. All right, so we're at the back of the disc. That's perfect. We're going to take the needle out, shot. Want to keep the guide wire in the disc. Shot. Okay, that's good. I'm going to come out. And we're going to make sure the guide wire doesn't move. So this surgery you're about to watch is only done at Deuk Spine Institute now in the entire world. And the reason is that it's not being taught to surgeons in their training, in their residency training. I have an open invitation to teach surgeons to do these procedures, but they require training. And unfortunately, it's a new technology, so there's no training right now that's being done. I learned by going and training with the South Koreans and the German doctor. And I learned how to do this surgery through them. And that was 15 years ago. I took what they did and I made it much better. I modified it. So it's like someone taking a jet and then making a stealth bomber. Shot. And I built the stealth bomber of a surgery because there's things that I do different than the South Koreans did. Shot. The South Koreans, for example, keep their patient awake. I always put our patients to sleep. And the reason for that, shot, is that when the patient's asleep, they're not moving around, so there's less risk of causing an injury to the patient. Shot. We're passing through some high-priced real estate over here. There's blood vessels and important things. Shot. I'm going to pull the guide wire back just a little bit as I advance the dilator. Shot. So the dilator is blunt. It's got a blunt tip. It's not sharp, and it just spreads the tissues, gently. And it takes it from about 1 millimeter or 0.5 millimeter diameter and spreads them out to 4 millimeters. And then I can put our tube down over that. Shot. So right now I'm feeling the front of the spine. Can you give me a little inline traction, please, Dr. Fu? Inline traction. Right now, just a little bit. Just a little inline. Kind of extend and pull, just slightly. Okay, good. Shot. Let's see where we are. That's perfect. You can relax. So we've had 1 drop of blood right here, 1 drop right there. And that's all we're going to have for the surgery. All right, let's get an AP view. I want to make sure we're in the... So there's 2 little muscles, one on each side of the spine. It's called the longus colli muscles. And my goal is to be right between them. And there's some space. It's about a centimeter of space. That's perfect. So, I think your image is reversed. Right? Well, let's see, yeah, it is. The endotracheal tube is on her right. That's backwards. There we go. Yeah, that's better. Of course, I knew that, but I was just working because it's not an issue for me, but anybody else watching may be concerned. Now, we are ready to go back to a lateral view. Did we ever figure out how to block the name?
Yes, we did temporarily figure out a way.
So are we capturing the x-ray pictures?
Yes, we are now.
All right, good. Okay. All right, so let's go back to a lateral view. The AP is perfect. The dilator is, can you flip that? The dilator is basically right in the center of the annulus, the center of the annulus and the anterior longitudinal ligament. All right, I'll need that inline traction again in just a moment, whenever you're ready, Dr. Fu.
Okay.
And just go ahead and give her slight extension and a little bit of distraction, just ever so slightly.
Okay.
Shot. Oh yeah, that's nice. I'm going through the ALL shot. We're inside the disc. Good. Can you feel me? Shot. Can you feel me? Pushing down. So I'm going to use a mallet. Shot. Almost done. Shot. Oh yeah, perfect. Okay, you can relax. So I've got my dilator all the way to the back of the disc, right where the herniation is. And now we're going to put our tubular retractor, which is how we do the whole surgery. The entire surgery endoscopically is done. Can you guys see this, Sean?
Yes, we can.
So this is a 4mm tube. It's called a tubular retractor. This is not a percutaneous surgery. Percutaneous is done with a needle. This is a real endoscopic surgery, and it requires equipment and training that 99.999% of spine surgeons don't have around the world. And that's why it's only done in a few places in the world. But this simple surgery will take away herniated disc symptoms, bulging disc symptoms, spinal stenosis, anything related to the disc. And all the other surgeons are still doing fusions with metal plates and cages or artificial discs made out of metal or plastic, when you don't need any of that. You can get it all done through a tiny 4mm cut on your neck. It can be outpatient. This patient will go home, hopefully, an hour after surgery. Depends on how deep asleep we are. Are you using propofol again? I like Tiva, but is there any way for you to monitor the depth so we don't have a long recovery? Do you need a biz monitor? Will that help you? Because we have a biz monitor.
Yeah, but
It doesn't help. The biz monitor doesn't help.
Biz monitor prevent recall. Propofol, people just lost all of this memory. They won't recall. Like if you use gas, that's biz monitor. More effective.
Okay. All right. I'm going to pull the dilator back just a little bit. I don't want it going inadvertently in. Shot. All right. So we're at the right level. 2, 3, 4, 5, 6. Everyone agree? 5, 6. 5, 6. And we're doing 5, 6, correct?
Correct, sir.
So we've got the proper level. Now I need to bring the tube through the annulus. So shot, maybe if you don't mind helping me again, a little bit of inline traction, just stabilize the neck. Just slight extension. Don't flex her, just extend her a little bit.
Yep.
Kind of tilt her head back. All right, so shot. 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 Sometimes I'll get to where the dilator will actually move forward or backwards as I'm advancing the tubular retractor. We're almost there. Shot. Okay, good. We're there. So nice job. You can relax. Thank you. And we're going to take out the dilator. Shot. That's it. Perfect. So 2, 3, 4, 5, 6. We're in the 5, 6 disc. We've gone through the front and middle of the disc. Now we're at the back with the end of the tube. And now we're going to do our endoscopic surgery. You're going to see inside the disc. Yep, watch it. Let's get that out. Okay, so for those of you watching, this is the Deuk laser disc repair. That's the actual name of the surgery. I developed it and pioneered it, and I am the inventor of the technology. We use FDA approved equipment. This is all developed by Wolf in Germany. But the actual technique of what I do, the annular debridement, that's something that I pioneered here at Deuk Spine Institute 15 years ago, and that's what gives us the great results, is the annular debridement. There's no other spine surgeon in the world that understands the value of the annular debridement. They all do discectomy, but they don't do annular debridement because they don't understand the importance of debriding the annulus as part of the surgery. It's never been described before, our paper that we published in 2012, where we describe the annular debridement. All right. So I want the irrigation, Louise, should always come off the top part of the scope, okay? The irrigation's on, right?
Yes, sir. Yes, sir.
So, can you guys see this, what I'm holding in my hand?
Yes, we can.
We call it the endoscopic rig only because, you know, like a big rig, you have the different parts, right? You have the cab that has the engine. You have a trailer. And this is also assembled like a rig where you have the camera. Can you guys see the camera? Don't let the laser fiber, watch Dr. Fu, watch the laser, here. Just watch this, I don't want it to get close to you. So, Sean, can you see the camera?
Yes, we can see
Yeah,
it.
this is the camera. This is the endoscope down to here. There's the laser fiber going in. It's 0.5 millimeter wide. We have irrigation, a light source, and then we're going to be able to use the laser to repair this disc. Yep. Luis is handing me my pituitary rongeurs that are built for this system to remove a piece of herniation. There's a piece. Okay. We're going to do most of it using the laser. Are we ready?
Lights off, please.
And we're going to turn our...
Over here.
We need the endoscopic. Thank you, sir. All right, there it is. There's the disc. The herniation, we're right in it. I'm going to sharpen up our picture so you can see it. That's all nucleus pulposus. I'm going to advance the laser fiber just a little bit so you can see it better. We're at 20.
Monica, 20?
All right, let's get it on and get going. Where's the pedal? Here it is. Here we go. All right, so the laser beam is coming out of the end of the glass electrode that you see. That transmits the laser energy from a machine at the patient's foot. And this is all herniated disc you're seeing right here. Now I'm going to be very careful. I'm not going to advance it further in. I'm just going to break up this herniation and then I'm going to clean up the annulus. So the nice thing is our patient has a relatively young herniation, and you can tell just by the consistency. Oh, there's a piece of herniation right there. See that? So we call that a reverse herniation when it comes back out. That was pushing up against the spinal cord and nerve, and we just released it and it pushed back into the disc space. But because the tube is in the disc space, it went up the tube. So there's a big piece of herniation right there. Look at that thing, it's a monster. Oh yeah. And remember, she has annular tear across the entire disc, side to side. So watch the loop so it doesn't hit my face. And you got to do this a few times before you understand the anatomy, because you can get lost pretty easily here if you don't know what you're doing. So please don't do this at home. There's the going out towards her right foramen. We're going to see it better in a minute. Now that looks like, see those fibers down there? Those are the back of the disc. That's the posterior longitudinal ligament. I want to shorten the laser fiber just a little bit, just so I can have better control over it. I think we're overexposed a little bit. Let's get the exposure down one click. Yeah, that's perfect. Okay. So we're going out towards the foramen on her right. And all of this is annulus. And this is the herniation. There's another piece right there. Okay. So I got to get it out. It's just, that one was on kind of on the left side and center. There. And we'll send that off to the pathologist to have them look at it and verify herniated disc. All right. Pretty cool. So we're actually inside the disc and we're looking at the herniation from the inside out. And there's part of the herniation right there in the foramen. See that? I'm zapping it away with the laser. Now just a little bit deeper to me is the spinal cord. So remember, we don't want to make the mistake of injuring the spinal cord. One spinal cord injury and it's all over. Okay? If you ever want to do this kind of surgery, there's no grace to having a spinal cord injury. You really want to be careful and do it right. Other surgeons have had it. It's certainly one of the risks. That's something I discuss with my patients. They understand that's a potential risk of the surgery, along with death and pneumonia and all the other bad things that happen, infection. But the truth is we've never had one, and I don't want to start. And I would recommend anyone who considers doing the Deuk laser disc repair endoscopic spine surgery on herniated discs that you make sure you get trained properly before you start doing these kind of surgeries. These are not easy surgeries to do. We make them look easy, but they're very complex. So we're inside the herniation. I'm zapping it away right here. I'd like to get this little white Casper the Ghost out because he's really annoying me. I'm going to the other side now, to her left. Just starting to get rid of some of this. See the big tear there? Okay, so let's go back. I want to finish up on the right side before I get too far on the left. And why is everything jiggling around? Well, it jiggles because the laser doesn't just deliver thermal energy, it delivers a shock wave, a pulse wave, okay? It's a process called cavitation, where it causes the water inside here to actually balloon in a pressure wave. And that's what's moving a lot of stuff around. Okay, that's normal. We expect that. That's actually part of using this laser is the cavitation effect. It helps me loosen up the herniated fragments once I've lasered them. There goes the reverse herniation right there. It just popped out of the foramen. I don't know if you guys caught that. It happens in a millisecond. So you'd have to go back and rewind it and look at it. That's the foramen. That blue is herniation. Yes, you have a question.
Yes, we do.
Look at that. Look at that.
One of our viewers is wondering,
Come out.
can you do the DLDR at a herniation at T7, T8?
Can I do this procedure at a T7-8 herniation? The answer is yes. We just started doing them this year. I was talking about earlier. Prior to this year, I would never do it. It's too dangerous. I didn't have the experience. Nobody ever trained me to do thoracic because nobody does it. So I actually had to pioneer it myself completely. And it's pretty scary when you are pioneering a new technology on the spine, especially near the spinal cord. So I wasn't willing to do it. I thought it was just not worth it because it was so risky. But I had a few patients who were desperate, who had nothing else that was working, and they basically begged me to do it. So I did it, and it worked. And they knew they were taking all the risk. They knew it, you know. We talked about it ahead of time. I was very honest with them. very open and honest, as all doctors should be with their patients. And they said, we trust you. And I said, listen, if I can't do it, if I smell trouble, if I see things are not going well, I'm going to stop before I hurt you, before I cause permanent damage. And they agreed. And so that was our agreement. I was willing to try it and let them be the first in the world to have an endoscopic thoracic disc repair. And they agreed to do it, but with the understanding that I would do my very, very best to make sure I was safe and not hurt them. Of course, you can't ever guarantee you're not going to hurt a patient, but they understood and they were willing to move forward under those circumstances. So it turned out that all 6 patients that I've done this year with the thoracic, they all had their pain completely gone after surgery, and they're all very happy with the results. It looks like there's a piece of herniation that went through that posterior longitudinal ligament right there. So it's sitting in the epidural space right there, and I want to try to free it up and get it out. This is the hardest part of what I'm doing today with this young lady. So I have to actually divide as I'm doing. There it is. You see that? That was amazing. That was sitting right on her spinal cord. And I just released the PLL fibers, and that reverse herniation, which we coined as well at Deuk Spine, it came out. So that was a big piece sitting on her dura right there. So that was pretty cool. Yeah. Like I said, it's unfortunate that other surgeons aren't doing this surgery. They need to be. But it's also a very difficult surgery to do. So it's not for every spine surgeon. It needs to be like the Mavericks, the top guns. That's what I'm willing to train, are the top guns. But the problem is I get a lot of spine surgeons who want to learn, or other people that want to do these procedures that shouldn't be doing them. And they're always trying to do it for the wrong reasons. And the right reason is to progress the field of medicine and give patients a better treatment than the fusions that are being done, and to give them a better outcome and a safer surgery. The wrong reasons, we all know what the wrong reasons are. That doesn't stop some of these doctors from doing these procedures for the wrong reasons. All right, any questions? We're almost done. I think 10 minutes maximum, 10 minutes. Dr. Fu?
Okay.
No other questions so far.
All right. So I'm not done with this area. I'm going to come peek at it again in a minute, but I want to get back to her main symptom side, because I've kind of gone off to her left side because I know she's having left arm symptoms now, and I'm going back to her right side, which was her primary problem. And I want to make sure I got everything cleaned up over there. So we're going to take another look. And again, this patient has a not so old herniation. So people who have had a herniation for a long time, they end up having a lot of scar tissue from the herniation, because herniations cause inflammation back here. And so you'll see like massive scar tissue just from the body's reaction to the herniation. And this patient doesn't have that yet, but she was starting to get more and more symptoms, and I knew she was developing more and more reaction to the herniation. There's another herniation right there. You see it, folks? Look at that. Another big piece coming out from the epidural space that was pushing on the nerve roots and the spinal cord, and now we just released it off the dura, and it's floating, because that's subligamentous. That's what we call a subligamentous herniation. It went through the posterior longitudinal ligament, so it's below the ligament. Those are, most surgeons don't even get those things out. I hate to say it, but a lot of orthopedic surgeons, they don't go this deep, even with an ACDF. So we're doing a phenomenal job of cleaning up all the herniations for her at this 5-6 level. Okay? That's where it was. It was right in there. You can see the tear down there. That's from her herniation, or disc herniation. I don't know her history of how she injured her disc. I don't know if it was a car accident or slip or fall, or if it was just those children, right? You know, making parents crazy. Huh? No, I know who she is. I'm joking. I'm joking with her husband who's watching right now. He's actually a good friend of mine. And yeah, he didn't want her to have a fusion. So he brought her to me because he trusts Deuk Spine. He knows us very well. And she needs to take it easy though, which I know he knows. We're way out in the right foramen at C5-6. Okay? Way out, way past, kind of into the foramen, past the uncinate process, for those of you who know your anatomy. And I'm just making sure we're not going to leave anything behind. I'm a little concerned here about this. To me, it looks like another herniation, and it is. Look at that thing. Bam, subligamentous, another one. It's going to come out, and it's big. This thing is just sitting on that nerve root. Hold on, let me get this guy cleaned up. He's blocking us. But oh yeah, there it is. And it's about to wiggle loose. Look at that thing. It's just rolling around in there like a ball bearing. And this is sitting in the right foramen on the right root. This is amazing. And those white fibers are the posterior ligament, the end of the disc, the posterior ligament and annulus. And you can see this thing just sitting here. Let's see. I'm debulking it, but it really looks angry. It said, oh, you discovered me. How'd you find me? How? And it looks a little calcified, to be honest with you.
We have a question.
Yeah.
One of our users is wondering, what percentage of relief do you expect from this procedure?
I expect 100% relief. I would be surprised if we don't get it. All of my patients get, on average, about 98% relief of their neck pain. So it would be unusual here. It'd be really unusual. Now this is different. This piece of herniation here is different. That thing is more calcified. See the golden colors? That's not soft. That's hard. I'm blasting it. Oh, there. Come on, get out of there. Get out of there. You can do it. Look at it wiggling around in the foramen. Incredible. No one else has seen this. In my residency program, they never taught us how to do this kind of surgery because it was so advanced, so new. I had to go overseas to learn. Brought it back to the States and have been making it better and better every year, every case. And now we have a really good procedure that works quite well. So there's still a little bit left here. You can see the laser breaking it up. And this was sitting on the right C6 nerve root, causing her severe pain and numbness and tingling. It's just in the armpit of the root. So the nerve root is above it to the right. And this, there we go. Come on now. Get out of there. Oh yeah. Huh? Give me a sterile high five. It's so gratifying to do this. And guess what? We're leaving the rest of her disc there. Okay? In other words, she's not getting a fusion. There's no need. We're not destabilizing her spine. Her spine is going to have its natural disc, and it's going to heal beautifully without any metal fusion, artificial disc. None of it's necessary. So all these companies selling artificial discs, folks, you don't need them. It's a technology far less advanced than what you're watching right now. You just need your surgeon to learn how to do the Deuk laser disc repair. There it is. All right, I think we got it. There's just a little bit of ligament or something left. And there's an old saying, don't gild the lily. Don't try to do too much. You're going to end up causing a complication. So people think, oh, well, will my disc look normal when you're done? No. The disc doesn't go back to normal looking. We've debrided the annular tear, and we've gotten rid of the herniation. We're done, Dr. Fu. So I'm just going to take one more look, and then we're going to close up, okay? And unlike the last case we did, closing is 30 seconds because we don't have a wound to close. I'm just cleaning up her left foramen to try to give her some relief on the left side. You can see the herniated disc right here. I'm just zapping it, cleaning up the tear. It's beautiful. You got the white down deep. You got the white posterior ligament. It looks intact. You see that? It's not torn. There's no hole in it. So all I got to do is get rid of this stuff here, and we're good. All good. It was really, the big one was on the right side, and we got that out, 95% of it. I'll just look one more time. I'm done with the left. Let's go back to the right. The only reason I even went to the left was because she's telling me she's getting more left arm symptoms. So let's pull back just a little bit. All this looks good. We're just about done, 30 seconds. I don't see anything more. Let's get this out. Let me look right here. Oh, it looks good. We're done. There's no more herniation. It's all gone. So I'll show you, folks. The whole surgery was done endoscopically with a true, it's called full endoscopic transdiscal approach. Transdiscal means I went through the disc. Okay. The disc itself doesn't care that I went through it. It's got no feeling. And hold on, did I suck it yet? No? Did I suck it out yet?
No, sir.
No? Let me have the dilator. I put the needle down. Yeah, I did. I sucked it out. Put a little happy juice. And then we're going to come out. And how much blood did we lose? 1 drop. Everyone see that? 1 drop. 1 drop of blood. Okay, every other surgeon in the world would do an anterior cervical discectomy infusion or an artificial disc. Major traumatic surgery. Okay, let's get all this up because she's waking up. I'm going to show you the incision, okay? I'm just putting a little bit of pressure in case we have some venous bleeding. You want to put pressure for a minute or two. And I'm going to show you the incision. Let's keep her down just for 1 more minute. She's starting to buck a little too much, but let's get all this out. All right, are you ready? And I'm going to show you the incision.
Yes, we can see it.
All right, so right here. Look at that, guys. It's the size of a pimple. Are you going to give her a little more, or are you going to just for a minute while we get the dressing on? I don't want her fighting us here. Just give her a little bolus. Luis, you'll dress her up. I don't see any bleeding, so it looks good. 1 drop of blood. Disc was repaired. We got to get her in a collar immediately. And I'm coming over to the conference room to answer any questions. Thank you, everybody. Good job.
All right, everyone. Dr. Deuk will be joining us in the conference room shortly to answer any remaining questions you have. If you look on the screen right now, we have the patient's MRI report up. You can see that this is what we use to guide our diagnosis and recommendation for treatment. At the level we just operated on, you can see there was a right paracentral disc herniation. And as you just watched, we removed that disc herniation using the laser and the endoscope. Go ahead and type in any remaining questions you have in the chat, and Dr. Deuk will be in to answer them shortly. All right. We have Dr. Deuk in the room with us now, ready to answer some of your questions. Go ahead and type them up in the chat now. I'm going to hand the microphone over to him so he can talk a little bit about the surgery you just watched.
I'm just writing here on my paperwork, how do you write such a small amount of blood loss, 1 drop? There is no spine surgery in the world that's 1 drop of blood loss. So this is the only one. What makes this surgery so bloodless is really the small incision, 4 millimeters. And obviously, it could be a very bloody surgery if we are off by 1 millimeter on my trajectory. What I mean by that is the disc is accessed percutaneously in the beginning of the surgery with a spinal needle, 18 gauge. And I'm going literally next to the carotid artery jugular vein. So this particular approach is more advanced than opening up the neck with an ENT surgeon or a neurosurgeon or a vascular surgeon where they're repairing the carotid artery or jugular vein. This is really, really tricky because you can't see those blood vessels, you can only feel them. And so you really have to know where they are. You have to have your hand on the front of the spine with your fingertips. You have to make sure you have a clear passage. And there's a technique that I use with the needle between my fingers so that it has basically a very narrow but perfect passage from the skin to the spine. Once you make that connection from the outside world to the disc safely with the spinal needle, then you can run a guide wire down the center of the needle, remove the needle, and then you use the guide wire, and you know that you're safe. You're not going through the carotid artery, through the jugular vein, through the esophagus. And so disc surgery could be very bloody. However, it's not because of the technique that's used and the small incision that's used. Also, the disc itself, as you could see, is not bloody. The disc doesn't have much blood at all. The disc really has no blood supply to the center of the disc. the disc itself has only blood supply to the outer annulus. Make sure they put a call in now. Thanks. So when you get past the outer annulus, which we did with the guide wire, then the dilator, once you get past that, you're not really cutting any blood vessels. You're just going through the avascular disc, the nucleus pulposus, to exit the backside and come up against the annular tear where the herniation is. That's what we did. And as we used the laser to remove the herniation and debride the annulus, you could see there was no blood, there's really no blood loss. And the reason for that is, again, the inner half of the annulus and the nucleus have no blood supply. So they're avascular, so there will never be blood loss when you're operating on them. However, the laser itself also coagulates blood vessels. So when we get to the outer part of the annulus where there is blood supply, every blast from that laser coagulates the little tiny veins and arterioles and capillaries that may start to bleed. So you're getting debridement of the annulus, but at the same time you're getting hemostasis through coagulation. So how come this surgery is bloodless? Number one, tiny 4mm incision. Number two, laser coagulates blood vessels as it does its work in the outer annulus. Number three, majority of the disc is avascular anyway without blood supply, so there's no blood to bleed. And number four, we keep the blood pressure down, keep it under control around 100 to 110 systolic, so it minimizes blood loss. And yeah, that's pretty much it. So bloodless surgery, 4mm incision, no hospital stay. This is all done outpatient. Patients can go home an hour after their surgery. And I know her husband and her children are waiting for her to go home and be with her and enjoy their time with her. And hopefully fixing this one disc is going to get rid of all the pain in both arms and her neck. That's what I'm expecting at this point. Now, she does have another herniated disc below, but it's very small, very, very small, and I don't think it's symptomatic. So, any questions, Sean? All right, well, I hope you enjoyed this Deuk laser disc repair, anterior cervical full endoscopic transdiscal annular debridement and discectomy to treat painful herniated discs and annular tear with radiculopathy and cervicogenic headache. I'm Dr. Ara Deuk-Majan, CEO and founder and pioneer of the Deuk laser disc repair procedure and the Deuk Spine Institute. If you know somebody with neck or back pain, send them here and we can help them. Most of our patients are cured of pain with their surgery, and some go on to have some residual pain from other areas that we can treat as well that usually doesn't require surgery. So we're the most advanced laser spine center in the world, and we have the best results in the world for endoscopic surgery and spine surgery. For this particular surgery, the Deuk laser disc repair, I've been performing this almost 16 years now with over 1,200 surgeries, and still 0 complications, 0 infections, 0 injuries to the esophagus, the carotid artery, the jugular vein, and spinal cord, dura, CSF, no complications whatsoever. The only thing that we've have is a 1% reherniation rate. So 1 out of 100 patients will reherniate their disc, and usually they know what they did to reherniate it. It's lifting something heavy or carrying something heavy or some type of an accident. But reherniation is definitely, a 1% is definitely a significant post-operative outcome measure that we need to monitor and be aware of. The herniation happens because the annulus has not repaired itself yet. It takes a year to fully heal the annulus. So until that year transpires, patients are at risk for reherniation. Other than that, we will be back in the operating room on Thursday. That's in 2 days to do another Deuk laser disc repair lumbar.